truly a pleasure for me to be here to talk about diagnostics for women's health, and also as a curtain raiser for a really wonderful panel that's coming up next. And if I aim to achieve two things this morning. One is to get us to a common understanding of what we mean when we say the diagnostic gap, and two, for us to try and understand some of the drivers that are driving this diagnostic gap for women and girls in Africa. And I'm glad Dr. Sultani is still outside, because I'm just going to describe problems, and he said he's tired of us describing problems. There are multiple ways to describe the diagnostic gap or to define the diagnostic gap. But in its simplest, truest form, the diagnostic gap is the time it takes to get an accurate diagnosis. And an accurate diagnosis is a factor of the right test at the right time for the right condition to achieve the right outcomes. And it's quite difficult to quantify the diagnostic gap for women and girls in Africa, because it is a factor of many, it depends on many parameters. But as we go through this, some of these concepts, right test, right time, right condition, right outcome, we'll start to unearth a significant, and dare I say catastrophic, diagnostic gap for women and girls in Africa. So if we start with the right test, for many conditions for women and girls in Africa, we know that the test that we're using is not the gold standard test. And by gold standard here, we mean the best possible test for that condition. So best possible test, best possible imaging solution, algorithm, whatever. We're not using the gold standard test. And if I take a couple of examples, so the burden of non-communicable diseases has been increasing on the continent, but, and this includes diabetes, so gestational diabetes has become a major issue on the continent. Now, the recommended gold standard test for screening for gestational diabetes is the oral glucose tolerance test. This is what is recommended by multiple diabetic societies globally, by WHO. And in the absence of that, a fasting or random blood sugar in that order. What is least recommended, and in some cases not recommended, I mean, by some diabetic societies not recommended, because of the physiological changes that happen in the kidneys in pregnancy, is what we use the most commonly in our antenatal care clinics, which is the urinalysis, the urine dipsticks. If I take another example, cervical cancer has been mentioned several times today. When WHO laid out the 10-year roadmap for cervical cancer elimination in 2020, they defined the screening target as 70% of women screened using a high-performance test. High-performance test defined as an HPV test. On the continent, we bear the greatest burden of cervical cancer, greatest morbidity, greatest mortality. It's been said several times this morning. But we're still using visual inspection with acetic acid or cytology in many of our screening programs. Many of our countries are yet to even transition to HPV testing as a primary mode of screening for women. Now, when we talk about why we're not using the gold standard test, the number one reason always given is cost. And we really need to get better at how we frame the narrative around the cost of a high-quality diagnosis within diagnostic test or solution within the continuum of care, and whether or not it increases the cost of care overall, because that's always the argument that if you use a high-quality diagnostic, then care becomes expensive. Other reasons given is that people are not aware of what the gold standard test is. It's not included in the essential diagnostic list, or there's no essential diagnostic list in the first place. And another argument that pops up is that it's better than nothing. So a lower quality, cheaper test, a lower quality or lower performing but cheaper test is better than nothing. This clicker is something else. So if we're talking about the right test, then a fit-for-purpose test requires context-specific data. And it was World Clinical Trials Day the other day, which is the annual reminder that clinical trials are barely conducted on our continent. So less than 4% of clinical trials that inform product development are conducted on our continent. And so this is a map from the NIH-funded clinical trials, from NIH-funded trials to date globally. And we can see how we stack up with the 1 billion population club. But what's interesting when you dig a little further is that when you look at the 19,000 trials that were funded in Africa, 11,000 are funded in Egypt and 3,000 in South Africa. So 14,000 out of 19,000 are funded in 2 countries. So even when we say less than 4% on the continent, we're really talking about 2 countries. And we also know that most clinical trials, actually less than 4, report sex disaggregated outcomes. So we know women are underrepresented in the clinical trials for product development, for products that affect them. So then we have to ask ourselves, is the right test regardless of sex, geographical location, geography, ethnicity, genetic composition? So then if we look at another concept, the right time. So the bulk of our population accesses care at lower level facilities. That's the first time they make contact. So it goes without saying, if we have diagnostics at lower level facilities, and that shortens significantly the time to diagnosis. So this is a study that was conducted in 10 African countries looking at the availability of diagnostics at 3 levels: basic primary, advanced primary, and at hospital level. The redder the map, the redder the graph, the less likely it was that the diagnostic was available. And what we see here, and actually what is of concern, is that basic tests for women and girls, like pregnancy tests, hemoglobin, HIV, that are critical for the well-being of women and girls, are less likely to be available at basic primary healthcare level than at hospital level. Another graph that comes from a study that was conducted in Mali, a referral hospital in Mali with 64 breast cancer patients. So each line, it was a time series, each line represents a breast cancer patient. And what they looked at is how long it takes for a woman from the time from this 64, from the time she suspected something was wrong to the time she got treatment. So the dark lines, well, you have to use your eyes of faith because I can see it clearer here. The dark lines represent the time to the first healthcare visit. I don't know what you're seeing, but the teal line in the middle represents the time to diagnosis, and the orange, the other dark line, is the time to treatment. So there are patient-facing factors that delay time to diagnosis, because as you can see, the time to first contact, it took quite a while. But then there's that second bunch where the women who made contact with the health facility, and it took an abnormally long time to get a diagnostic, ranging for anywhere from 2 weeks to 130 months. 130 months is simply a system failure. And so some of the reasons that were given for why it took this long, so they're the patient-facing sides that we need to deal with around. They did not know something was wrong, or they went to, so this is the patient-facing side, went to a traditional healer. They were afraid, the provider, but the system-facing side were, the providers did not know what they were dealing with. The diagnostic was simply not available, or women were referred to a different level of care, and then they never completed referral, so they were lost to follow up. Now, if we look at one more concept, the right condition. So we've had this over and over this morning. Typically, when we talk about women's health on this side of the world, on the continent, typically we're talking about maternal health, family planning, STIs, HIV, where our funded programs sit. And these are critical issues that we need to deal with that are grossly underfunded. But this is a graph from the most recent Global Burden of Disease study that shows that our life expectancy as women, average life expectancy is increasing. So we're living longer into our 60s, which is great. Except when we look at where we are focusing on right now and where our funded programs are focusing on right now, then we realize we're barely scratching the surface of the needs for women on the continent. So if you think about a woman, as somebody said, from the time she's born, right into her 60s, we're barely scratching the surface of the needs or the issues that affect their health and well-being. And this graph from the World Economic, from a report that was released this year, you must have seen it, the 1 trillion gap report that came out at the World Economic Forum this year tells us exactly that 5% of conditions, so what they looked at, they used the same global burden of disease data, and what they looked at, again, I don't know what you're seeing, use your eyes of faith. So on your right side, so what they looked at is the conditions that were contributing to the total global burden of suffering. And what on the right side, 5% of conditions are conditions that are female specific, so maternal health and gynae conditions. 51%, so the combination of the teal and the orange, 51% are either conditions conditions that affect women differently or disproportionately. And what this tells us is that we're barely scratching the surface of the issues affecting women and girls. But secondly, what was interesting is that 5%, because we expected that 5% to be a bigger contributor. And during this year's International Women's Day, I asked one of the authors of this report, I had a coffee chat with them, and I asked them whether that 5% was an underrepresentation, and they said yes. Because when they looked at the data available was largely for what we look at as women's health conditions today, maternal health, STI, so traditional what we look at as women's health. But when they looked at the issues that we know are prevalent, that are significant on the continent, like infertility, polycystic ovarian syndrome, fibroids, endometriosis, pelvic pain, all the other conditions that are gynae conditions, that are female-specific conditions, including the cancers, there wasn't enough data. And so what this tells us is that there are a lot of conditions that largely remain undiagnosed. And so I started by saying that the diagnostic gap for women and girls in Africa is actually quite difficult to quantify, and this is why. For the large majority of the conditions, or the issues that affect women and girls' well-being, the answer is that we simply don't know, because there's a significant proportion that we don't know that is undiagnosed, or we're not even dealing with in the first place. And so we have to ask ourselves then, how do we move, because as Daniela was saying, we're starting with diagnostics in this session because that's the first step in the care pathway. But how do we move women along the care pathway if we don't even know what we're dealing with in the first place? So it's been doom and gloom until now, so I'd like to close with some good news. That you must have seen all these announcements this year. So 2024 is a good year for women, and there's a lot of attention and focus and funding for women's health this year. But, and I know this is supposed to be good news, the challenge is, and this fills me with a lot of trepidation and joy, equal parts joy and trepidation, because the gap in women's health is not just an Africa issue, it's not just an LMIC issue, and particularly the diagnostic gap. It's a global issue. And what, if COVID taught us anything, is that when an issue is a global issue, we get forgotten. And so I want to leave us with two thoughts. One is that it's important that we keep engaging in fora like this, with the federation, with the coalition, because as this cake is being baked, served, sliced up, it's important that our needs keep being represented and they're front and center. Otherwise, we will get forgotten. And two, when we talk about our needs, it's important that we remember that our needs are changing. Our life expectancy has increased. Our global burden of disease is changing as African women. And so while the critical issues that we've been focusing on remain core, front and center, it's important that we get out of, we're using a telephoto lens. It's important now we look at the wide angle lens and look at the issues of women across the entire continuum. And one question that keeps coming up is, but then if we start focusing on all these other issues that women face, then what happens to we'll take attention away from the critical issues that we haven't even solved in the first place. And to that I say it doesn't have to be a zero-sum game. Focusing on one does not mean taking attention from the other. And as women, we don't have the luxury of only suffering from the conditions for which funding is available. Even if we don't talk about them, we suffer from them. So it's important to keep shedding a light on them. And as I close, I want to use a quote that was used by the authors of the World Economic Forum report, the 1 trillion gap, that the solution is not to cut up the small pie that's existing and try and make it stretch to fit all of our problems. Because as women, we are used to stretching the sauce. It doesn't matter how many visitors show up, we will stretch the sauce and we will make it work. The solution is to bake more pie. Thank you.